First question, I'd like to know how you see the difference between home oxygen therapy compared to hyperbaric oxygen. So, there are some differences, some perspectives, of course. So, based at the evidence for both options, home oxygen and hyperbaric oxygen, is, I would say, relatively low, and in general, they can give some little benefit on daily function to at least some patients. So the difference is hard that hyperbaric oxygen also have, at least in some studies, some sort of anti-inflammatory effect. It's not only about the oxygen route, but also about reducing inflammation. But on the other hand, hyperbaric oxygen usually are very much expensive, need to be done many times, sometimes also more than once a week, need the patient to be moved from home to the place that does the hyperbaric oxygen. And other problem about hyperbaric oxygen is that not many centers offer it to under 18 patients. Conversely, particularly for those severe patients who can have severe post-exertional malaise, severe crashes, home oxygen can help in relieve some symptoms or somehow to speed recovery, can be done at home. And so it is more comfortable for the patient, and it's usually much cheaper compared to hyperbaric oxygen. So I would say, as a balance, considering the relatively low evidence for both approaches, I would prefer the home oxygen. So that was first question from Donna, and thank you. The other question was about the effects of low dose rapamycin. So first of all, let me remind you that I've checked today, on March the 9th, there is, so Sunday, March 9, there is a post on low dose rapamycin, the rationale, and why we are increasing it. There is a lot of enthusiasm of it. Many patients have reported strong benefits from low dose rapamycin, and there is a trial is starting in the United States. I have sent an application, so wish me luck for a study also in Italy, a trial on low dose rapamycin in patients aged from 14 to 35. So many patients with both long COVID and pre-COVID myalgic encephalomyelitis, chronic fatigue syndrome. And as I said, I've started some patients as off-label. I'm starting either colleagues that have developed long COVID, or some patients I'm following from quite a long time. So for this type of therapies, we also need a strong reciprocal trust, because these are off-label conditions. Patients, of course, need to sign agreements, but I'm proposing them to patients that are really committed in trusting the options we suggest them. We are having a positive effect. I have to say, yes, definitely yes. The patient is a colleague. She's younger than me. She's probably 30 years old, maybe a few less. She is a great neuroscientist. She was struggling since 2 to 3 years with severe fatigue, brain fog, severe pains, tachycardia, inability to go to work full time, to apply to grants, to do research. Many times she needed to tell her boss that she needed to go back home. Post-exertional malaise. She also set me in confidence. And this is a topic we will need to discuss more, that she was even struggling to have more intimacy with their partner because of this malaise and the fatigue. And I've met her like after 2 to 3 years. She was struggling with these symptoms because probably she was shy to share with me these problems. She was also starting thinking she had a psychiatric condition, so she was thinking about going to a psychologist or a psychiatrist, despite she's a neuroscientist. Eventually, someone convinced her to share with me her problems. We did the usual tests we do: the cardiopulmonary exercise testing, the POTS tests, CT scan, and other tests. And eventually, I proposed her to use only rapamycin without the other medications I usually use, like ivabradine, enoxaparin, gabapentin, because rapamycin has the potential not to treat the symptoms, but to treat the primary root of the disease, which is a chronic activation of inflammation through a specific route, which is called AKT3, which is not controlled, chronically stimulates T cells, and therefore T cell inflammation, which is documented in long COVID. It's also discussed in the blog or in my book. And so we started very small doses. We use weekly dose, so only once a week, oral route, so it's very easy to be done at home. We increase dosages every week until 5 or 6 milligrams per week. The patient is now, since more than a month, to a full dosage of 5 milligrams per week. And she was great, actually. She still is great. She told me she's not feeling since some weeks fatigue, post-exertional malaise. She was also able to go to San Francisco for a big psychiatric meeting, which she was really willing to participate. She's also back to Rome now, and she didn't have any post-exertional malaise. So what we do, we also do baseline and after 6 months, some specific tests which can document that there is this per chronic stimulation of T cells, and she had these abnormalities before starting the medication. And we are planning to do this test again after 6 months of therapy, because we, in line with clinical improvement, we also want to document a biological improvement to make our findings even stronger. So this was a question from Margot. Thank you very much. Moving to next question from Ryan. Can MCAS, which is mast cell activation syndrome, can be linked to viral persistence? So this can be linked with a viral infection. So we definitely know that viral infection can trigger mast cell activation syndrome. We do not know if this has a reciprocal effect with viral persistence. So my personal opinion, so which is not evidence-based, the virus of course plays a role in long COVID and other post-viral chronic fatigue syndrome. I'm not sure if the chronic viral persistence chronically stimulates immune cells, or an initial viral infection with specific viruses like COVID or Epstein-Barr virus kind of switch on a pathway of chronic inflammatory response, which the organism is not able, for some reasons which we don't know yet, to switch off. The low-dose rapamycin is a medication which is able to switch off that specific pathway I mentioned you before. but also other medications we use, like intravenous immunoglobulins, also has the potential to switch off the immune system, to kind of reset the immune responses, or other biological agents as well. So this is why I use those medications. I usually use intravenous immunoglobulins before rapamycin, because with intravenous immunoglobulins, we have decades of experience with several immune-mediated conditions, while low-dose rapamycin is something cheaper, of course, more comfortable because the patient can take it at home, but much newer. So I want to try before some medications I have more experience with. And now I see a question from Manu, which is in line with what I said before. Yes, the patient is back to work already. She traveled to San Francisco for this important meeting in neuropsychiatrists. And as I said, I'm planning to check the B and T cells markers at 6 months of treatment. So even in case I will start this medication for some of you, the plan will be that we will do with some immunologists I work with. We will do some baseline tests. We start the medication. We continue for many months. We don't know yet when to stop. So most probably we will continue at least 1 year if, of course, the patient improve. And every 6 months, we will check the markers to see if we both have a clinical and biological improvement. Or in case we don't have a clinical improvement, if this is also linked with no changes from immunological perspective. So thank you to Manu, to you as well. I have another question from Hannah. So my child has a sensitivity to vibration, movement, and noise. We are not able to push his wheelchair as it is painful for him, or moving fast in car. Have you come across with this problem with anyone? So like a super sensitivity to pains and stuff like that, yes, although I confess probably not as much severe as in your case, but maybe not as much severe as in your case because we treat earlier these painful syndromes. We don't know yet exactly why some patients have this such widespread pains, even with very minimal touches. But we empirically hypothesize that this can be some sort of peripheral nerve, small fiber neuropathy, which particularly in children, it's difficult to find someone who is willing to do skin or muscle biopsies to document small fiber neuropathy. And we treat it with gabapentin. So probably this is one of the reasons we don't arrive to such a severe degree of pain. Gabapentin has multiple effects. Historically, it's used as an anti-seizure medication, but it has anti-inflammatory effects as well, and multiple other effects other than the seizure activity, anti-seizure activity. It's also a very great medication for difficult to control pain, headaches, chronic headache, but not only, even neuropathic pain, post herpes zoster pain. And we are using quite a lot in our patients with pains or headache after COVID or other viral infections. And also gabapentin has also a little effect as a mood stabilizer, which can be useful because some patients have a really impaired daily life, and also working on mood can help patients. So these medications is a medication we like a lot because has really multiple effects, and it is usually very well tolerated, and we are using it a lot in several other pediatric neuropsychiatric disorders. A question from Michelle: do you test viral persistence, and what is your experience? No, unfortunately, we don't test viral persistence because we don't have a kit yet. Although I've been in contact in the end of the year and even some weeks ago with a company. It's called Atomaker, something like that, who published some studies about a point of care test who is able to give an indirect evidence of viral persistence. So we are trying to understand how I can use this test maybe as a research test at the beginning, because when it's research test, patients can companies provide us for free, so it can be useful to test it in some other courts. So in case I will start using that point of care test, I will inform the community, of course. And a question from Ryan, which is still linked with viral persistence, is: do you have good results with Evusheld? Evusheld is a anti-SARS-CoV-2 monoclonal antibody. I don't have yet good results because I've never personally used it yet. As I mentioned in previous post, I'm starting to get information about Evusheld because some clinicians actually, and some patients have reported a strong improvement in using monoclonal antibodies. So this is why I'm working with the national agencies of medication or drugs to have it. It's quite hard so far. It's months and working on it, and probably something is changing now. So I don't have personal experiences. So when you ask me, will I improve soon or not? What I can tell is that there are some publications, small case series, showing patients have improved or even for a long time using anti-COVID monoclonal antibodies. We don't have trials yet. We have independent researchers which in meetings have told us that they are improving with Evusheld. The medication is safe, very well tolerated, but it's under strict control from the national agency, so it's difficult to have it. And many drug companies are not producing it anymore, or are not the national health systems are not buying it anymore, because as acute COVID is much less severe now, severe in terms of mortality rates, clinicians are not using anymore anti-COVID monoclonals to treat acute infections. So the costs are high, the governments are not buying it, and therefore it's difficult for us to have it even as off-label for long COVID. This is why that can be accessed only through the private route. Okay. Thank you very much. Many people are joining. It's many questions, so I'm also joining it. Thank you very much. Hope this is helpful. So Azel asked us, how many children do you have taking ivabradine? Is it generally well tolerated? Yes, ivabradine is actually the medications we are using more in patients with long COVID. I think I've used in at least 50 children, but probably more. And it is very much well tolerated, because ivabradine, compared to the classic beta blockers like propranolol, first of all, don't have effect on mood, because propranolol, like other beta blockers, can have kind of an effect on mood, to lower the mood, to kind of trigger a bit of depression. And also ivabradine mostly control the inappropriate increases in the heart rate, but does not lower baseline heart rate too much. So because some patients have maybe when they are laying down or sleeping, they may have 50 or 60 beats per minute, but when they stand up, they can arrive to 120 or 30 according to the ages. This can vary a lot. So this mostly control the inappropriate increases, have a very short half-life. So usually I prescribe it as soon as patients wake up and in the afternoon, so that the drug levels in the blood are very small during night when it's physiological for the heart rate to go down. So this makes the medication very well tolerated. It's easy to monitor the effects on a 24-hour electrocardiogram, and any problems we can stop it, and the effects vanishes very quickly. But I have never had any side effect on it. The only problem is the medication is teratogenic, so cannot be used in pregnancy, so patients need to be aware about it. Another question now from Giuseppe Lanorcia. I read that Pretorius signed an agreement with the lab in Basel to run and detect the microclots. Is that a test you would consider useful, cost-effective to add to your protocol as a valid biomarker? So the test can be, of course, useful. So I'm not using it because we have another test in my hospital, but this needs to be done on fresh blood. We didn't have funds anymore for that specific test. So I'm not using it because I give it for granted that patients with long COVID have endothelial inflammation. And when the endothelial cells are inflamed, they activate the immune cells, including platelets. And there are now countless studies that have documented on the major journals that patients with long COVID have endothelial inflammation, endothelial activation, and microclots. So, of course, if I would have easy access to such a test, I would use it routinely, particularly in case if this will not be too much expensive for the patients. But in case I don't have this test, as most of you know, I still treat as off-label and with agreements with families and patients with low-dose anticoagulation, and see and monitor clinical response, because until we prove otherwise, we can give for granted that patients with long COVID have an endothelial inflammation, because this has been documented by countless studies so far. This is not a theory anymore. This is proved. Any paper have confirmed it. So now question from Man: what do you think about antivirals? So, and the combo Movirac statin. So so far I'm not a big fan of antivirals. I would only try the COVID monoclonals, because antivirals, most studies have either documented no effects or a small effects. In my opinion, antivirals can be useful during acute infections. So if you guys have a reinfection, you should take either antivirals or metformin, which reduces the risk of long COVID. But once long COVID is developed, in my opinion, it's not only about the viral persistence, but it's also about something that happened to the immune system. So you either try both to target both the virus and the immune system, or you will, in my opinion, you are not succeeding. And if I have to try something for the viral persistence, I would prefer the monoclonals, because they are safer. Antiviral medications, the classic pills, antiviral medications also have several side effects. So, in my experience, antivirals are never much tolerated in the medium to long term. So this is why I'm trying to work to focus on monoclonal antibodies rather than long-term Paxlovid or Maraviroc as well. Statins, so I mostly follow children or young adults up to 30 to 35. So this is why I use statins much less compared to adults, because the lipid metabolism, the endothelial health is much better in younger patients. So far, I only have a few exceptions of patients older than 40, 45, because I really had a strong relation with these patients, so I eventually accepted them. But usually I don't go over 30, 35, and I don't have many problems with lipid metabolism. So another question with Donna, we have 5 minutes left. Are there any risk treatment for suspected POTS if it's not possible to get a diagnosis? So like salt, etc. So I say having a diagnosis of POTS is so easy that I can also suggest you some tests to do. I don't know where you're based. It's very easy. You just do a 24 hours electrocardiogram with heart rate variability and a 10-minute stent test, both of them, and send me the results. It's so easy and so cheap to do this test that I actually suggest you to force and find a solution to do this test rather than self-treating. So I never suggest self-treatment, of course. Gaia is looking for the futures, and do you think in next year it will be possible to have some approved treatments? So to have approved treatments, I stand formally approved systems, I think we will need a long time, because governments so far not even have a formal diagnostic code for either long COVID, particularly long COVID, or myalgic encephalomyelitis. But I think we will have evidence from some effective treatments, which we at least can use somehow in Italy. So for younger patients, I see a better future compared to historical patients I diagnosed 10 or more years ago. And Mariko Kell asked the benefit risk balance for Evusheld. I think I replied to that. Yes, the benefit risk balance is a positive balance because the monoclonals have been used a lot during COVID. They are very much well tolerated. So I don't expect major side effects. And this is the main antiviral I would feel safe to try. And this is why I'm working more on Evusheld than monoclonal antibodies rather than antivirals. So we have no reason to expect any specific side effects, only allergies or stuff like that. Margot, thank you for your time. It's my pleasure. I'm enjoying it a lot. Would the VIG be suitable for someone 3 years in? Yes. Usually I use IVIG in the most severe cases, hoping that a stronger effect of IVIG can give some positive effects in terms of clinical improvement. 50 to 60% of patients improve, at least some improve some symptoms like pains, some brain fatigue, and so this also gives optimism. Maybe after we improve with IVIG, we can start thinking about other medications like low dose rapamycin. Danko, do you have any patients that use gabapentin saying they have lesser vision than before using it? No, honestly, I've never heard about that, even in other patients that are using gabapentin for other reasons, not related to long COVID. Never heard about that. Have you read about from CRE a promising monoclonal antibody, Cipavibart, which has been approved by EMA? Will we be able to obtain it for long COVID? So the problem is not about new or old monoclonals, but it's about having them approved to be used for long COVID. We will not have it approved to use for long COVID unless we have trials, and no trials are undergoing now. So I don't think before 5 years we will have a formal approval of a monoclonal. I'm sorry to say that, for a monoclonal antibody for long COVID. So we will need to find a way to use it as off-label, unless you guys spread the voice, you arrive to the EMA, to the European, to the FDA, you spread the book to everyone. This is why I've written it, because even for us as a doctors, it's being very, very difficult, because we are also alone. It's very difficult for us. We are struggling to have any medication of you. We take a lot of responsibility. Would you try, this is a great question, for rapamycin, the child? Yes, in a severe case, I would try it, because low dose rapamycin is already used in children as well. This is used in children with immunodeficiencies or other genetic disorders affecting the mTOR pathways. So this is already used in pediatric patients for other reasons. As I always tell you, I'm not doing experiments with new drugs that have never been used in humans, including in children. So, Carlotta, I'm sorry you have not heard about that, because I've written several notes, and we are 50 people more than last time. So I think we are having more success. I'm sorry you didn't receive a medication. Small fiber neuropathy can be completely solved. So we know this. We are treating these conditions since the pandemic, so we don't have long-term results yet. So I don't know. I will not feel honest to say yes, we will resolve it completely, but we can a lot improve it, and to improve it, or at least slow a much progression. Margit, do you have experience with ketamine? I have experience with ketamine for analgesic sedation in children with traumas who need sedation for fractures, but I've never not used as a chronic medication, honestly. So, I work in the emergency department. When we needed to sedate to make a child sleep, we use it. Otherwise, no. And Bea, this is an Italian question, but I will translate it. Bea, we are closing now, but you can feel free to write questions in Italian, and I will translate. And my English, I think it's easy to be understood. Thank you, Juan, for your greetings, for appreciating it. How long the treatment for monoclonal antibodies would last? I will do only one infusion, so you will need only half a day in the hospital, and we monitor how is it going. Have you been seeing from Hazel patients with pandas? Yes. We don't have the FRAT tests, but we are using. We are now have had good results in 3 patients with pandas with intravenous immunoglobulins. About myalgic encephalomyelitis as result of long COVID, as I always say, I'm treating long COVID and myalgic encephalomyelitis in the same way, because I think it's not ethical to treat long COVID and offer many options to long COVID patients, but not to patients with myalgic encephalomyelitis. So I treat both the same way. I think disease overlaps so much that it's okay to treat both of them. So, guys, 2 minutes and I have to close, because I also promised my family this was gonna last 30 minutes. Is there a baseline supplement stack? I use a supplement which is called Immuplus Auxilia, which contains a lot of vitamins, zinc, magnesium, quercetin, curcuma, all have anti-inflammatory effects and stimulate innate immunity, which is important in antiviral activity. And this is also in a response to Marie last questions from vitamin B1, B2, B3. Yes, not at very high doses, but this supplement I mentioned also contains vitamin B1, B2, and B3. So thank you very much. I think it was super funny. I loved it. I like that you did several questions. So I think this version today was more successful than the other time. So we will definitely keep doing at least once a month, but I will try to do it twice a month. Thank you very much, and see you next time. Please feel free to share if you like it. Bye bye.